All right. Case number 25, COPD. Bernice Bettwiller is a 73-year-old retired seamstress who has never been married. She worked in an alterations department at a men's clothier for 48 years. She is a chain smoker. On the job, she was never found without a cigarette hanging from her lips. When her employer announced that smoking would no longer be allowed in the store, Bernice retired. Since her retirement 3 years ago, Bernice has not been feeling well. She fatigues easily, even with light exertion. She has shortness of breath and recently has begun to sleep on 2 pillows. Okay, so she needs to sit upright. However, despite these problems, she has refused to stop smoking. Okay. Bernice has made an appointment with her physicians who note a prolonged expiratory phase in her breathing, expiratory wheezes, and increased anterior-posterior chest diameter. Okay. So, prolonged expiratory breathing, okay, wheezing. Her nail beds were cyanotic. She has moderate pitting edema of her ankles. Okay. Based on these observations and the results of the laboratory and pulmonary tests, her physicians conclude that Bernice has a combination of emphysema and bronchitis, okay, called COPD, which results from her long history of smoking. The results of her pulmonary function and laboratory tests are given on these tables, respectively. Okay, so her vital capacity is decreased, makes sense. Residual volume is increased. That happens in COPD, so you retain more air in the lungs. You can't get it out. Functional residual volume increases. Makes sense because functional residual volume makes up the one part of the residual volume. These two are linked. That's what I'm saying. And then expiratory flow decreases. Okay. Bernice's laboratory values. Her hemoglobin, normal range, hasn't changed. PaO2, arterial partial pressure of oxygen, is very low, very decreased. O2 saturation, that's concerning. 78 should be 98 to 100. PaCO2, very much increased, very high. Well, not too high, but higher than normal, 69 out of 40. And then bicarbonate, 34. Normally should be 24. All right. So question number 1. Bernice's chronic bronchitis is associated with inflammation of the airways and hypersuction of mucus, which lead to obstruction. Inflammation of the airways, hypersuction of mucus, which leads to obstruction in her airways and an increased airway resistance. Her emphysema is associated with loss of alveolar capillary units and decreased lung elasticity. How are these changes in airway resistance and lung elasticity? How do they explain the result of her pulmonary function tests? Okay. So we have some pretty good equations, right? So it's like compliance. So lung compliance will equal the change of volume over change of pressure. And then also elasticity. Oh my god, I spelled that so wrong. T is the inverse. Right? So change of pressure over change of volume. put it together, lung compliance and elasticity are inversely proportional for the same reason. If you plug in these two equations, right? So this is asking us lung elasticity is decreased. Explain the results for pulmonary function test because of it. So for change is that lung elasticity has gone down. That means that the change in the pressure has gone down as well. And we can look at her laboratory values. And there you go. It's gone down. Partial pressure of O2 has decreased. Significantly? Yes. More significantly than the pressure of CO2 at the same volume. So, okay. And then let's see. Okay. Which has led to an increased airway resistance. Airway resistance equation. I think airway resistance is going to be equal to this thing. R to the fourth. So it's like resistance will be equal to 8 times the length of the airway times I forgot what this is, over the radius of the vessel. So if they're saying she has an increased resistance, it means that there must be an increase in either the length of the vessel or the what is this variable? I don't remember what this n is, but it's like, we'll check the answer in a bit. Alright, so her emphysema is associated with loss of alveolar capillary units. Okay, so there's less alveoli overall, less alveoli capillary. So there's not even a chance for there to be any gas exchange because of this. How do these changes in airway resistance and lung elasticity explain the results of Bernice's pulmonary function test? So I kind of said it with the lung elasticity, right? So we know that lung elasticity will be equal to the decrease in the difference between the partial pressures, and therefore it'll correspond to these, and then change in airway resistance. So we're also saying that airway resistance is increasing. So she has COPD. So there's more retention of air. I'm pretty sure it's this variable that we're looking at. Or it could be the radius of the vessel has gone down. That's another. There might be like constriction that's causing constriction or loss of those capillaries. Let's see the answers. Okay. Right. God. Right here. The pulmonary function test shows that Bernice has increased residual volume. Yep. Increased FRC. decrease vital capacity and decrease expiratory flow rate. Okay, so increase RV, therefore increase FRC. These go together. Then decrease vital capacity and decrease expiratory flow. That's not really, yeah, whatever. Recall that residual volume is the volume that remains in the lungs after forced maximal expiration. Functional residual volume, FRC, is the volume that remains in the lungs after expiration of a normal tidal volume. Two components of Bernice's disease leads to these pulmonary changes: increase in resistance, yeah, we've been talking about that resistance, and then decrease in elasticity. So the bronchitic component of Bernice's COPD caused narrowing and obstruction of her airways. Oh, look at that. Yeah, it's going to be the decrease of the radius in that resistance equation that we were looking at. But anyway, so this results in increased resistance. Yeah. So caused narrowing and obstruction of her airways. This resulted in increased resistance of the airways this resulting increased resistance caused a decreased airflow. Yep. Especially during expiration. Okay. Because the expiratory phase was comprised, air was trapped in the lungs, and residual volume was increased. Residual volume increased. Yeah. So it shifts. That's exactly what they're saying. Like, more air gets trapped, and then residual volume has to increase because you can't let it go. It's like the common obstructive disease issue. Because FRC includes residual volume, FRC was also increased.